All right. Hello, everyone, and thank you for joining us today. I'm Ruthie Marker, the Education Program Manager at the Allergy and Asthma Network. I'm excited to welcome everyone to this afternoon's webinar. We have a great session planned, and I'm pleased to introduce our presenter, Dr. Jonathan Lyons. With his extensive knowledge of allergy and immunology, we can look forward to an enlightening session. Before we begin today's webinar, I have a few housekeeping details to cover. First, all attendees will remain on mute during the webinar to minimize distractions. We are going to record today's session and upload the webinar later this week. You can access all of our recorded webinars and upcoming webinars on our website at allergyandasthmanetwork.org. Scroll to the bottom of the page and you can look at past webinars and future events. Our webinar is scheduled to last 1 hour, and this will include time for question and answer. Please feel free to submit your questions at any time throughout the webinar in the Q&A box located at the bottom of your screen. A team member will be monitoring the chat for any questions that come through or should you need any technical assistance. This Advances webinar is brought to you in collaboration with the American College of Allergy, Asthma, and Immunology. ACAAI offers continuing medical education credits for physicians and attendance credits for others. You can create a free ACAAI account to earn CME or attendance credits for these Advances webinars through their member portal. All attendees will receive a certificate of attendance. Please note that no additional continuing education credits will be provided. A few days after the webinar, you'll receive an email with supplemental resources, information, and to download your certificate of attendance. With that, we'll go ahead and get started with today's presentation titled Symptom Diagnosis and Treatment and Options for Mast Cell Disorders. Mast cell disorders encompass a range of conditions characterized by abnormal presence or activation of mast cells in the body. This can result in a wide spectrum of symptoms, some of which are subtle and easily overlooked, while others can be debilitating and life-threatening. Due to the heterogeneous nature of these disorders, the varied ways that they can manifest, diagnosis can be challenging. It is my pleasure to introduce today's presenter, who will equip you with evidence-based knowledge and practical strategies for recognizing, diagnosing, and managing mast cell disorders. Dr. Lyons is a professor of medicine at UC San Diego, where he leads a laboratory that uses genetic and translational approaches to identify critical mechanisms and pathways of allergic inflammation and hypersensitivity that can be targeted in first human clinical trials. Dr. Lyons' work has been pivotal in defining the field of primary atopic disorders. His discovery and characterization of hereditary alpha-tryptase changed the approach to evaluating and diagnosing mast cell disorders and reactions. Dr. Lyons has published over 80 peer-reviewed articles and authored several chapters and multiple textbooks. He has also presented numerous abstracts and invited to lectures nationwide and to international meetings. Dr. Lyons has been named a Lasker Scholar and has received awards from Quad AI and the Jeffrey Modell Foundation. With that, I will go ahead and hand it over. Thank you so much, Dr. Lyons, for being here. We all look forward to your presentation.
Yeah, thanks for having me. It's always a pleasure to speak on topics near and dear to my heart, including mast cells. So I'm happy to speak with you all today and thank the network and the college for inviting me to give this lecture. I do have some relevant disclosures here that have all been mitigated. So those are there for you all to see. So by the end of today, the hope is that we will have better skills at understanding what clonal mast cell disorders are and understanding how we approach these patients in terms of diagnosis and treatment. We'll also kind of delve into a little bit of sort of some of the newer kind of things on the horizon that we're excited about in the field, and kind of backtrack a little bit in terms of showing how we kind of extrapolate from what we know about clonal mast cell disease and how we try to apply that a little bit to non-clonal disorders such as mast cell activation syndrome. So this is kind of the key player in the story. This is the mast cell. This cell actually is born kind of as an immature precursor in the bone marrow. It's a myeloid lineage cell like other granulocytes. So if you get a pimple and they have pus in there, that's a granulocyte. Those are neutrophils. But mast cells, they grow up and they don't mature fully, and then they circulate, and then they land in tissues, predominantly mucosal tissues or in the skin, where they, under the direction of some of the proteins and cytokines that exist in there, including stem cell factor, actually become granulated and fully mature, kind of grown-up cells. And they hang out there for a long time. And they can accumulate at sites of inflammation or infection or tissue damage, and we think that they help fight some of those bugs that are around, as well as help promote the healing process. So there's a lot of roles that mast cells play, but usually when we think about mast cells, at least in the context of disease, we're often thinking about immediate hypersensitivity. So we're thinking about mast cell degranulation. So there's these secretory granules in mast cells, shown here as kind of those blue little dots. The big one's the nucleus, obviously. And when they degranulate, they release a number of compounds, including those shown kind of at the bottom here: tryptase, heparin, platelet activating factor, or PAF, histamine, leukotrienes, and prostaglandins, or what some people call lipid mediators. Those are generated kind of after the fact. And then IL-6 and TNF alpha. So those are cytokines, inflammatory cytokines. And it's sort of this slew of molecules that we sort of collectively refer to as mast cell mediators that are released in this context. And they drive a lot of the symptoms that we think of. So we have flushing, hives, and swelling, low blood pressure or passing out from low blood pressure, abdominal pain, diarrhea, nausea and vomiting occasionally. And then some other less direct symptoms, such as brain fog, bone pain, fatigue, some of those kinds of symptoms that we think may be driven by some of these mediators in different ways than sort of this acute problem. Now, canonically, mast cells are activated by antigen, right? So most people, when you think about like what's an allergic reaction, you have a kiddo who's allergic to peanuts. They eat some peanuts, shown there in that big red dot. There's IgE, that's antigen made by B cells, that's sitting on the surface of mast cells, bound to a high affinity receptor. That peanut protein cross-links those IgEs, and that causes activation of the mast cell and release of all these components. But there are a number of other antigen and other kinds of receptors, including cytokine receptors, such as KIT, which is the stem cell factor receptor, or anaphylaxis. So C3a and C5a are anaphylaxins. And they have specific receptors on the mast cell, and they're derived from complement, which is a sort of an ancient part of the immune system that's designed to sort of fix on infected cells and kill them. As well as MRGPRX2. So this is a sort of a newer kid on the block in terms of an activating receptor of mast cells that's been described in first drug reactions to fluoroquinolones, for instance. And we think it's probably important for sort of a scavenging type role, where lots of different things can kind of tickle this receptor and drive to mast cells to become partially activated. Importantly, none of this occurs in isolation. So this is all sort of a threshold type event where each of these different pathways can be tickled or stimulated a little bit, and can kind of lower that threshold for the mast cell to become activated and degranulate. So these actually, virtually all of these are being targeted in therapies or considered as targets of therapies right now, either in development or actually available for clinical use. And we'll kind of get to the treatment portion at the end. So how do we make a diagnosis, at least of clonal mast cell disease? So systemic mastocytosis, the indolent form, is the most common version of this clonal mast cell disorder. And basically what happens in this disorder is that one of these mast cells gains a change in its genetics, that it starts to grow a little bit unopposed. And so the most common change is a gain-of-function mutation called D816V that's in KIT, and that's the one clinical test that's available to look for this. But it can be really anywhere in the gene, although it's usually in sort of defined areas that drive any gain of function in that gene that can be associated with this disorder. But it's important to know that you can't make this diagnosis without a bone marrow biopsy. So there is one major criteria, and there are 4 potential minor criteria. And in order to get the diagnosis, you have to have one major and one minor criteria, at least according to the WHO guidelines, or 3 minor criteria. There is a separate guideline that allows you to get the diagnosis of mastocytosis with just the one major criteria. But to be perfectly honest, if you see multifocal dense aggregates of mast cells in the bone marrow, so there's greater than 15 cells per high power field. So the pathologist looks under the microscope at the highest power of their microscope, and they see more than 15 cells in a dense aggregate. almost always you're going to get at least one or two minor criteria associated with that. So it's a little bit not so important that there's a discordance between the two. Importantly, these three that I've highlighted, either those multifocal dense aggregates, these funky shaped mast cells. So these are spindle shaped atypical mast cells that are sort of the first minor criterion, and you have to have at least a quarter of them that look funny. Or you have to have unusual markers that shouldn't be there on mast cells. So that's CD2, CD25, or CD30. These are markers that are usually on other kinds of cells, but not mast cells. So we call them aberrant. And so if those are on the mast cells, and they have to do special staining in the laboratory. So if you're a physician ordering this from a pathologist or a hematology oncology doctor to do the bone marrow biopsy, you have to specify, we need to stain for these things. We need to stain for mast cells with either KIT or tryptase, and we need to stain for these aberrant markers, CD2, 25, and 30. So if you don't get a bone marrow a biopsy that's not in the skin, I should mention. So this has to be a biopsy that's not just isolated to skin, because this cutaneous form of mastocytosis also exists. Then you can't get the diagnosis. Importantly, there are two other minor criteria for diagnosis. I mentioned the gain of function mutations in KIT, but also having a tryptase above 20, and we'll kind of dig into a little bit how the 20 level is a little bit in flux right now based on WHO guidelines, where they say to adjust it for the presence of hereditary alpha-tryptasemia, which is something we described in my lab almost 10 years ago. So what's it look like? So it's not subtle if you find it, but it can be spotty. So sometimes these can be missed. But this is an example of mastocytosis in a patient. And so here you can see this was a bone marrow biopsy. And I think you can see on the left with the H&E stain. So that's a standard hematoxylin eosin stain, excuse me. So this is kind of the basic laboratory staining technique that they do for basically any first pass. And what you get here on the left is this kind of disruption of the marrow, this kind of cellular dense space, where normally you would see these kind of fat spots. The circles are fat in the marrow, and this is an adult, so that's a reasonable amount of fat. You shouldn't have like lots and lots of cells like this, so that's abnormal. And you can see a little disruption of the architecture, so it's not sort of looking homogeneous across the area. When you stain for tryptase, oftentimes people will stain for KIT as well. Either is okay. You will see that there is this dense aggregate. You can see way more than 15 cells in this area. And you can see some of them are spindle shaped. So if you look to the side with that long, skinny looking cells over there on the kind of the far right, those would be considered, I'm gonna just get my laser going here. Oops, excuse me. Those would be considered spindle shaped. So in addition to the bone marrow biopsy, one of those minor criterion is identifying these gain of function mutations. So what tools do we have to do that? So there are 3 commercially available tests, 2 of which are completely useless in evaluating patients for mastocytosis. The first on this list is a myeloid NGS panel. So this is really designed to identify patients suspicious or who were suspicious of having cancer. The reason that it's useless in mastocytosis is that the limit of detection, so the LOD for D816V mutations, is 5%. That means 1 in 20 copies of KIT in the peripheral blood would have to be mutated with a gain of function variant, most often D816V. The issue in mastocytosis, if you recall, mast cells grow up in the marrow, but then they deposit in tissues. We think that most patients who have mastocytosis have the mutation in the bone marrow, and then that single clone grows out and goes, but it's only one circulating cell or a few at a time. And so the frequency is much, much, much lower than 5%. This isn't a circulating cell type. And so using the NGS panel, we really can't detect this disorder. The next one, actually, I'm going to skip down to the ASO PCR. That's allele-specific PCR. That's what used to be used, and that used to be the gold standard. And you can see it's an improvement on NGS, but we're still only at 0.1%. So that's still one in 1,000 samples, and that's still insufficient. The advancement really recently in technology, really in the last maybe 5 to 10 years, is the development of something called droplet or digital droplet PCR. This is a much more sensitive technique, and it's the one that should be ordered currently when we're looking for D816V, and it's available pretty much at every major clinical laboratory now. And you can see, again, we're doing a factor of 10 better, roughly, than the allele specific. And that's the best we can do right now with a lower limit of detection, usually reported out at about 0.03%. And that actually does pretty well. It's not perfect. As you can see, this is data from an abstract that was presented this last year at ASH, the American Society of Hematology meeting. And there are better techniques sort of in the wings. So these research tests down here, duplex texting or RCA, which is rolling circle amplification, you can see that, again, we're doing about tenfold better again. And it's likely that some of these may become clinically available in the next year or so. Importantly, the duplex sequencing allows us to look for not just the one variant that's common in adults. So 95% of adults have D816V, only about 5% with mastocytosis have a different change, at least based on the literature right now. It may be a little higher than that, but that's kind of the current dogma. That said, in kids, it's a different story and it's a different disorder. And many kids don't have D816V, so we have difficulty identifying what the change of what the variant actually is. And so this duplex sequencing would not only be more sensitive, by a factor of 10, but also give us a broader specificity, right? Like we would actually be able to find more variants that are likely clinically meaningful in this gene. Okay, so I mentioned that this tryptase of 20, while that's still the recommended guideline, that the WHO now says that we're supposed to adjust it for this HAT thing. So what is this hereditary alpha-tryptasemia thing? So hereditary alpha-tryptasemia is a common genetic trait. It's present in just shy of 6% of the general population in the United States. It is caused by extra copies of this TPSAB1 gene, shown here in red, when it encodes for alpha tryptase. So in everybody walking around, TPSAB1 can encode for alpha or beta tryptase, as the name would indicate. Tryptase, the full name of the gene is tryptase alpha beta 1. And whereas TPSB2, shown here kind of in black on the side, only encodes for beta, you can either have alpha or beta at that TPSAB1 locus. Now, when you have extra copies of alpha, they're sort of a replication of the adjacent alpha, so you would get 2 at a time, or 3, or 5, or 10. We've seen up to individuals with up to 10, that's shown here down on the bottom left. And this leads to higher blood levels of tryptase because of overexpression of the replicated copy. And so with each extra copy, rather than going up by a factor, or like from 4, which is the general average in the general population of the serum tryptase level, to 5, you go from 4 to actually to 14. And so knowing this was really kind of the major driver of a tryptase level, we wanted to try to figure out what's a normal tryptase. So you can see here in data that we generated while I was at NIH a few years ago still, these are all individuals that had tryptase genotyping performed and had blood levels of tryptase measured. So on the y-axis is tryptase, and on the x-axis is the number of extra copies. And this is log-log transformed, so it just basically condenses the data a little bit. First, I hope you can appreciate that this line is pretty straight, right? It's not like a curve. So it's a pretty linear association between the number of copies and the tryptase level. Over here, you can see if you have no tryptase or no replications, your log transform value is close to 1. And then as you go up, you can see this sort of stepwise increase or gene dosage impact of 1 extra copy, 2, 3, 5, 7, and 10 extra copies on the baseline tryptase level. And from these data, we could determine what an actual upper limit of normal is based on this major genetic driver of tryptase levels. Lots of other things have been reported to affect tryptase levels, but essentially this is really the only thing that's clinically meaningful. Weight, size, age, smoking, except for renal failure, advanced renal failure, this is really the one thing, or clonal myeloid disease. This is really the one thing that impacts, at least commonly impacts. Renal failure is fairly uncommon locally, and myeloid disease is quite rare. So based on these, we were able to identify new upper limits of normal, and quite fortuitously, actually, the upper limit for people without replications is actually 11.4. And I say fortuitously because most clinical laboratories report the upper limit of normal as 11.4. And I can get into sort of the back of the napkin dumb luck math that got those levels to actually be the same. But it just has to do with the prevalence of HAT in the general population and how these clinical laboratories pseudo-normalize data. So Importantly, if you have one extra copy of tryptase, your upper limit is close to 40. If you have two, it's close to 60. If you have three, it's close to 80 or 90. Four, it's 100, 120, although, the sample size is quite small once you get kind of that far out. So, there probably is some more variability in those data than we realize. But, it's important because this would alter that 20 level as to what should be what upper limit of normal and what you would use to sort of try to diagnose or identify patients who likely have mastocytosis or clonal mast cell problem. And so there have been two proposed ways to try to adjust for this. Neither is accepted yet, but both have been published, and ours has data behind it. The other is just sort of expert opinion, and both work pretty well, actually. So with one's important caveat. So if you look at that middle level, those are the upper limits of normal. Well, first of all, the top one is the average level of tryptase, the median level for each group of individuals with extra copies or those without. The middle line, that upper limit 99.5% probability or predicted interval, those are the levels that we came up with based on our data. And then the last one, the bottom line, was sort of a simplified method to try to figure out how to adjust for this. And it assumes that we're using that 20 cutoff as what's abnormal. And so basically what you do is you take the tryptase level from the patient and divide by 1 plus the number of extra copies. So if they have a tryptase of 10 and they don't have HAT, their upper limit would be 10. But if they have, their normalized level would be 10, I should say. But if they had a tryptase of, let's say, 50 and they had one extra copy, then you divide it and you'd say, oh, the tryptase is 25. And so by being 25, it would be above the level of 20. Now, if you invert that sort of situation, you see that you would have to get a tryptase of 40 if you had one replication, 60 if you had two, and so on, in order to get above that 20. Interestingly, and I think quite nicely, those levels match up quite nicely with our predicted levels. So 40, 60, 80, 100, 140, 120, awfully close until you get way out here where those levels are probably a little bit spurious and it's hard to know exactly what's normal or abnormal. The important caveat is that it doesn't adjust for people who don't have hereditary alpha-tryptasemia. So I suspect in the end, there may be some sort of consensus recommendation where the recommendation is if you don't have HAT, 11.4 is your cutoff. If you do have HAT, you can use either of these methods, but the numerical one's probably a little easier. Although I'll show you at the end there a link to we have developed an online tool, so you don't have to memorize any of these numbers. You can just put in your patient's genotype, you put in their BST level and baseline serum tryptase level, and then you'll just get it'll spit out whether they're below or above this line. So why do we care? Like, why is this important and how does this impact patient care? So this was a gentleman we saw a few years ago now who began anaphylaxing to peach in his 40s. And he had had 2 episodes of bona fide syncopal anaphylaxis after a peach ingestion, had eaten peaches before, never had a problem. There are parts of the world where peach allergy is more common, but he was in the North America and the United States, and that's not a super common allergen here. His exam was benign. He didn't have any hepatosplenomegaly. He didn't have any skin lesions. And so we measured a tryptase and it was 14, and he didn't have HAT. So we performed a bone marrow, and this is an aspirate from his bone marrow. And what you can see here are KIT positive cells on flow cytometry. So this is basically a really cool instrument where you can stain the cells with an antibody. There's an attached fluorophore that kind of, if you hit it with a laser, it emits light. And then you basically make all the cells march and file past lasers and detectors, and you hit them with a bunch of lasers, and then the detectors see those antibodies that are on there as these kind of little dots. So each one of these dots is a cell from the patient's bone marrow aspirate. And the ones that are stained for KIT positive in these 2 upper quadrants are all mast cells. You can see they stain very brightly for KIT. But also you can see 2 of those aberrant markers, CD2 and CD25, are also positive in about half the cells. So this is a clonal population of mast cells expressing these aberrant markers. And so this patient would meet criteria for monoclonal mast cell activation syndrome at the time. But he was also KIT D816V positive, so now he has 2 minor criteria, but he still doesn't have all 3, and his bone marrow otherwise didn't show any aggregates or abnormalities. However, if you adjust that tryptase level, because he had it above 11.4 and he didn't have HAT, now he meets criteria for indolent systemic mastocytosis, and that has very important implications for third-party payers and getting him treatments such as D816V targeted therapy should he need it. There's also important implications in terms of identifying patients who have high tryptase in the absence of HAT. And so it's not just clonal mast cell disease, although it's mostly clonal mast cell disease. I just wanted to show a couple of studies and show you how rare it is to have a tryptase even above 8 in the absence of mastocytosis or hereditary alpha-tryptasemia. So this was almost 700 patients. You can see less than 2% of them had a tryptase above 8 that we couldn't explain by either HAT, systemic mastocytosis, or both. And in this kind of yellowish, brownish, goldish fragment, you can see that only 5 out of the 671 had a tryptase above 11.4 that we couldn't explain. And in all 5 of these individuals, we found somatic variants or germline variants in these genes that are predisposing genes for myeloid malignancy or myeloid dysplasia. And so it really suggests that having a high tryptase in the absence of having HAT is indicative really of a myeloid neoplasm, most commonly mastocytosis, but potentially others. And a second group showed effectively the same thing, that only 3% of those without clonal mast cell disease or HAT had a tryptase above 8, and found that having a high tryptase in the absence of HAT had a specificity of almost 98% of identifying mastocytosis in their cohort it was actually a fair number of patients. We generally think of using tryptase as a screening tool because of this. However, the sensitivity is actually fairly poor. And so it's important to send, but it doesn't rule out the diagnosis of clonal mast cell disease. And so these are 2 consecutive studies of venom allergic patients, largely from Slovenia, where patients were screened not just using peripheral blood D816, or not just using serum tryptase levels, but also peripheral blood D816V. And I hope what you can appreciate here is that the median tryptase levels in these patients with clonal mast cell disease and venom anaphylaxis, so these are all bee sting anaphylaxis patients, the average level hovers around 4 to 5, which is the same as the general population. And there are outliers you're going to pick up, but the majority of patients have a normal tryptase, certainly below 11.4. And so, while it's important to measure the tryptase level and it is helpful, we need to really be making sure we're also screening for D816V in patients who have syncopal anaphylaxis, particularly to drugs and insect stings, or even pre-syncopal, anybody who anaphylaxis badly, and particularly adults, and certainly be sending peripheral or both the peripheral blood D816V and the tryptase level in these patients. So moving from sort of diagnosis of clonal disease to diagnosis of reactions, tryptase is useful there too. And the reason I'm talking so much about tryptase is because it's really a unique protein in that it's made in abundance by mast cells and made almost exclusively by mast cells in healthy individuals. And so historically, based on some old experiments that we really couldn't do anymore, where Larry Schwartz's group took bee allergic patients and then stung them and then measured their blood to see what went up. You can see in the white dots that are not highlighted with the arrow, that's histamine going up, and it goes up very quickly and then comes right back down. So it's not super useful unless you're right there when an allergic reaction happens, like it's going away within minutes. However, tryptase goes up and stays up for a little while. So you can see the scale on these graphs changes. So the top 2 are up to 4 hours and the last one goes out to 12 hours. And you can see within that first 4-hour or so time period, you're getting pretty good elevation over baseline. But once you get out to about 6 hours, you're kind of losing that difference. Importantly, if you look closely, if you measured it right away, those tryptase levels are low initially, at least in A and B. I'm not sure what's happening in C. So you can see if you measure it too soon, within like 15 to 20 minutes of the reaction, you might actually miss the rise. So the goal is around an hour. Certainly 2 is still fine. 4 is probably okay. If you get out to 6, it's a little too late. But based really just on observation, it was proposed that an increase of tryptase of roughly 20% over your baseline plus 2 nanograms. So let's say your baseline's 5, or let's make it 5. It would need to go up by at least 3, right? 20% plus 2. And so if you go from 5 to 8, that's consistent with the clinical diagnosis of anaphylaxis. Importantly, in all of the algorithms and all of the position statements on the diagnosis of anaphylaxis, tryptase is not included because it's a clinical diagnosis. So while it's useful and helpful, it doesn't help you, it doesn't actually make the diagnosis of anaphylaxis, the clinical presentation does. But tryptase isn't the only mediator that rises. So the other ones that are measured are really metabolites of important mediators. I mentioned, excuse me, histamine going up right away. Well, one of the major metabolites of histamine is N-methylhistamine, or NMH, shown in that green chart, the third one over. And that can be, well, so first of all three of these other than tryptase are measured in urine, but that one can be measured historically in 24-hour urines. But now patients, or there, some people are doing a spot urine collection where they do a spot N-methylhistamine to creatinine ratio as opposed to a 24-hour collection. But the gold standard still, I think, remains a 24-hour collection. And in addition to histamine, there are breakdown products of lipid mediators. So that includes 2,3-BPG, or BPG shown over here, which is a sort of a terminal degradation product of prostaglandin D2, is really kind of what we think is sort of where the business is mostly. And then LTE4, which is the terminal cysteine in that sort of pathway that has a longer half-life than the others. And while you can see, these are all patients who had physician-diagnosed anaphylaxis. You can see that on average they go up. In some folks, they don't rise super substantially. And if you look on the far right, the tryptase level increase shown in the dashed line, that's the median level, is far above what we sort of established as sort of the upper limit of difference, 1.685. That'll explain where that number comes from in a second. One of the complications or difficulty in using these markers is that we don't know how variable they are and what else they're sort of associated with. And so oftentimes they're measured in patients being evaluated for clonal mast cell disease or even non-clonal mast cell disease. But we don't really have clear identification of what a level should be or is. Importantly, Matt Gianetti's group showed that the most common clinical association with having elevated urinary mediators was allergic rhinitis. And importantly, the folks that had it the highest, they showed actually went down substantially with immunotherapy. So it was likely local activation by allergen of mast cells in the nose that once patients became sort of desensitized through allergen immunotherapy or allergy shots to the environmental allergens, they stopped making those prostaglandins and they normalized. So I just thought that was fascinating and interesting. Importantly, we don't know what variability of most of these are. We have data that I'll show you in a second on tryptase, but we do know that they are variable. For instance, if you take mast cells and grow them in culture, we see that there's sort of a diurnal variation in secretion of histamine. There's also variation by age and size of histamine. And so it's hard to you have to adjust the what's a normal level based on those factors. And we don't really know how variable it is in humans who are asymptomatic. But we do know how variable tryptases are, at least in this real world study that we published a few years ago. And so these are patients with either allergic disease of a variety of allergic diseases or hereditary alpha-tryptasemia who had serial measurements. Each individual little colored line is a different person. It's showing by age, so you can see each individual over time, but also in the cohort as a function of age. And I hope you can appreciate that there's no real trend by age or time. These levels kind of go all over the place. And the same is true among patients with mastocytosis. So they even go all over the place even more, including this guy where it went from in the hundreds to over 1,000 and then back down again, despite having no acute symptoms. And so this worried us a little bit in terms of the usefulness of using 20% plus 2, because going from a couple hundred to a couple thousand is way more than 20% plus 2, and really suggested that maybe this sort of standard math wouldn't apply as well or work as well for patients with high tryptase levels. So we sought to try to identify the simplest way to determine what a meaningful change in tryptase levels is. And suffice it to say, what we try to do is maximize both the sensitivity and specificity of using a ratio. And we found that just a simple ratio of an acute level to a baseline level was the easiest way to do this. And we identified these three different cutoffs where this ratio of 1.685 maximized both sensitivity and specificity. So basically gave us the biggest bang for our buck when we were trying to use tryptase to identify people who were having immediate hypersensitivity reactions. And again, you don't have to memorize these ratios because there's a nice tool that I'll show you in a second that exists online you can use, but I just kind of want to show you how the data perform. So that optimized level in green is that 1.685 where sensitivity and specificity are maximized. You can see that there are still some people, these are all just baseline levels, these first four graphs or groupings, should say. And you can see that there's still some people whose variability is falling outside of those ranges. And we also identified two others where it was like a high probability and a low probability, because oftentimes as clinicians, when we're seeing patients, we have a pretest probability. We have someone perhaps who's had a really passive exposure to an atypical agent that's not usually an allergen versus someone who ingested a common allergen and had never had it before. Or just got an injection of a medicine or a bee sting that they identified, right? So the pretest probability is quite different. And so that's why we identified both high sensitivity and specificity thresholds that are shown there. Importantly, the high sensitivity threshold of 137 captured everybody on that far right who was diagnosed by a physician as having anaphylaxis. And so we thought this would be a little bit of an improvement, and we wanted to see just how much it was. So we took all of our patients and using our cutoffs found the false discovery rate and compared that to what it would have been had we been using 20% plus 2. And you can see that we were finding still about 4% were being misclassified when they were just kind of having baseline variability using our new kind of optimized approach. Whereas using the 20% plus 2, almost 1 in 4 basically, we're being falsely classified as having mast cell activation when they were just having baseline variability. Others have seen the same thing, actually even a little bit more profound than ours. It was a smaller study, so it may have sort of exaggerated the effect size, but they saw almost half their patients would have been misclassified as having mast cell degranulation or activation. And so while the 20% plus 2 works great if you have someone who has a normal tryptase level, like around 4 to 5. In fact, 20% plus 2 and 1.685 are exactly the same for a level of about 4.6, which is roughly the median level in the general population who doesn't have HAT. It kind of falls apart when you have a patient with a high tryptase. So if you have a patient with HAT or if you have a patient with clonal mast cell disease, we would recommend using the ratio. And I think this has been relatively well established across groups and is being recommended by consensus statements now as well. So this is the calculator. It's called Tryptase calculator. It's misspelled on purpose because it's the total rise in peripheral tryptase after systemic event. And as of today's taping, presentation, et cetera, it hasn't been taken down from the NIH website, so that's good. So here you can just plug and chug. So you put in your baseline tryptase level of your patient, the acute measurement, and then you have these three choices. It defaults to the possible clinical suspicion, so that's the optimized. But if you think it's likely, that's the high sensitivity ratio, and if it's less likely, that's the high specificity. So you can use your clinical judgment here as opposed to just having to stick exactly to a formulaic decision. You go in there and you say, okay, I think it's possible. I don't know. This history is a little fuzzy. And then you ask it to analyze your data, and then you get this result. And basically, you have this blue line, which is the threshold. So first of all, the yellow line is if it didn't change at all, and below that, nobody cares, right? So it's grayed out. If you, because then the tryptase went down and not up, and you wouldn't be on the website, I assume. The blue line is sort of, if you're below that blue line, that's just baseline variability. But if you're above that blue line, that's consistent with the clinical diagnosis of anaphylaxis. Now, let's redo this. So if you had 22 and you went up to 30, which would meet 20% plus 2, and you do the same calculation, you see that now this patient just has baseline variability, despite the fact that the 20% plus 2 rule would have said that they had a mast cell degranulation or was consistent with anaphylaxis. And that's really what's this improved specificity that this other approach provides. And I would point out down here where these two lines cross, where they're identical, that's about 4.5. Okay, so what about these other mediators and how are we using them? So I talked sort of ad nauseum now about tryptase, so we can ignore that. I would point out again that all the others require urine testing. In most cases, a 24-hour urine. Some specialized centers may be doing spot urines, although I haven't figured out how I might even order that at this point. But what about these other guys? So ignoring tryptase, I would point out there's no consensus on the level that you need to meet to reach anaphylaxis for any of these others. Some people have proposed a doubling, even for the 2,3-BPG shown down there. That's the 2,3-dinor-11-beta PGF2 alpha. But the data that are published, which are limited, would suggest cutoffs closer to at least 2, if not 4, or 10-fold, depending on the mediator you're measuring. Conversely, when we're trying to diagnose clonal mast cell disorders, there are cohort studies showing fairly good specificity of specific levels being associated with clonal mast cell disease in patients that are already diagnosed. And so those levels are a little bit more, a little bit better established. Excuse me. Sorry about that. Okay, so that's diagnosis of anaphylaxis of clonal mast cell disease. And we generally use the same approach or increase in mediators in terms of diagnosing mast cell activation syndrome. And so basically all of the same stuff is just translated. Now, this is sort of an algorithm looking at this, moving from diagnosis to management. Okay. And so importantly, and I think one thing that gets often overlooked is patients with clonal mast cell disease often have bone problems. They develop osteopenia, osteoporosis, osteoporotic fracture, lytic lesions, and have a lot of bone pain often as well. And so, we talk about, things to potentially measure over time, including tryptase levels, D816V allelic fraction. Importantly, excuse me, measuring bone density over time is critical, especially if they have early onset bone density issues. Excuse me, man. So some patients with clonal mast cell disease are asymptomatic. Obviously, that chunk kind of goes away when we're talking about non-clonal disease because these patients would be symptomatic. And there's kind of 4 primary domains. There's dermatologic, gastrointestinal, neuropsychiatric, or musculoskeletal. And you can see the initial sort of treatment approach is really histamine blockade, predominantly H1, although H2 can be added. When we talk about GI symptoms, oral cromolyn's often invoked and used, and it is effective and helpful in some patients. Certainly, patients with bone density issues, getting them on calcium and vitamin D supplements is important. And then from there, we move into sort of second-line therapies. And you can see that, excuse me, leukotriene receptor antagonists are often recommended within sort of the dermatologic and GI domains. Some patients in selected individuals, aspirin can be used, and because it can block the generation of some of those lipid mediators that we discussed. And then certainly for skin, GI, and systemic anaphylaxis, omalizumab is kind of in that next category. Use of bisphosphonates or RANK ligand inhibitors or other sort of advanced drugs, we usually sort of seek out support from our endo colleagues to do those things. And that's really kind of the next step, right? So when we talk about managing these patients, we need to engage our teammates, and this is really a multidisciplinary approach that needs to be taken for these patients when they present with complex features. And then finally, as we move beyond sort of all of our dermatologic, gastrointestinal, neuro and psych and endocrine consultations, when do we think about sending for hem-onc evaluation? And so I'll kind of get into some of those symptoms, but that's at the time, same decision point where we would consider any tyrosine kinase inhibition, and certainly avapritinib is the only one approved for systemic mastocytosis. I would mention that, in the chronic spontaneous urticaria guidelines, cyclosporin is an add-on therapy to omalizumab, and, whether that or a substitution like tacrolimus might be of benefit in some of these patients isn't really well known. And similarly, dupilumab, which is now approved for chronic spontaneous urticaria, but isn't incorporated into the guidelines for treatment of those patients, may fit in somewhere into this algorithm in the future. This was just sort of the yardstick that we published in the annals recently, based on sort of a cohort of expert opinion. So when do we consider referral or potentially cytoreductive therapy with tyrosine kinase inhibitors? Well, it's really patients who are having uncontrolled symptoms or disease, in particular B findings. And so these are patients who are sort of tipping towards what we would call smoldering if you have 2 or greater of these B findings. And so that's lots of mast cells, so greater than 30% in the bone marrow, really high tryptase levels above 200, or a variant allele frequency of their gain of function mutation, most often D816V, of greater than or equal to 10%. They start to have hepatosplenomegaly or other organomegaly without impaired function yet, or they have abnormalities in their bone marrow that look like myeloproliferative neoplasm or myelodysplastic syndrome, but don't meet the criteria as laid out by the WHO. And these are all of the areas that can be affected in advanced disease. And these are really patients who can get quite sick and we need help from the or oncology docs. As I mentioned, the only FDA-approved drug for systemic or indolent systemic mastocytosis is avapritinib. So that blocks specifically the D816V gain-of-function variant kit. Doesn't block nearly as much. It's quite selective. It does hit wild-type kit a tiny bit on a higher dose. But people are also working on a number of other drugs. Midostaurin and imatinib are approved for advanced disease, but should not be used in indolent systemic disease and really should be reserved primarily for either specialized centers or hematology oncology doctors. But BTK inhibitors, other selective KIT inhibitors for targeting D816V, or non-selective TKIs that block KIT, and even monoclonal antibodies against KIT are all in development right now for treatment of systemic mastocytosis. And there are other drugs that are being developed for other diseases that may also be applied, but these are specifically under study for systemic mastocytosis. So these are QR codes to those two tools on the NIH website. One's called BST Calculator and one's called Tryptase Calculator. So either one you can find if you just Google them as well. But here, hopefully these would be helpful to you as well in practice, or if you just kind of want to learn about yourself and you have tryptase levels, you can play with these a little bit. So the key takeaways really, BST levels are variable and likely these other mediators are as well. And we're trying to work to understand how to control or how to adapt our understanding of use of them in order to better use them for diagnostic purposes. Because right now the variability is impacting our ability to correctly interpret them. It's important that when we're interpreting a tryptase level that we're thinking about HAT and making sure we understand what of the tryptase level is contributed to by that, and that having a tryptase above 11.4 is really suggestive of mastocytosis or another clonal myeloid issue. That 20% plus 2 rule works great for patients with normal tryptase levels, but really that ratio is important to consider when we're talking about patients with high levels. Hopefully not in the near future, we have better assays than we did, but hopefully we'll have even better assays to detect these gain of function variants very soon. But currently we still have to use a biopsy of a non-skin tissue in order to make the diagnosis of mastocytosis. So I think we have a ways to go there in terms of non-interventional or non-invasive diagnostic testing. And finally, we do have lots of, it's exciting that we have a drug approved for ISM, and hopefully we'll have others in the not too distant future really to help our patients better. And so with that, I'm happy to take some questions. I always think this is kind of a fun slide that Jason Gottlieb commissioned years ago now, saying, I think they're in cahoots talking about tryptase HAT, mastocytosis, anaphylaxis, and mast cell activation. So yeah, happy to take any questions that people might have.
Thank you
Thanks.
so much, Dr. Lyons, for that presentation. I know I learned a lot, and I hope that our audience did as well. So I have a couple of questions. One, I feel like you touched on, so I'll ask it, and maybe you can elaborate. Are tryptase levels always elevated in mast cell activation syndrome?
No. So in general, actually in any of these disorders, the HAT's the only one where the baseline level is consistently elevated. So in MCAS, really what we're looking for is an acute increase during a symptomatic episode. And that's what helps us get that diagnosis of MCAS.
Awesome. Thank you so much.
Mhm.
We have time for a couple of more. What strategies do you use to counsel patients when with mast cell disorders on trigger avoidance, medication use, and emergency preparedness? And how do you tailor this guidance for different patient populations?
Yeah, so generally speaking, obviously it's every patient's different, right? I talk about, there are common triggers that we know of, and I generally review those with every patient with either clonal mast cell disease or recurrent mast cell activation, which include certain medications like NSAIDs or narcotic type medications that are direct activators of mast cells, alcohol, exercise, physical, emotional stress, temperature changes or temperature extremes are all sort of common, and exertion are all kind of common causes for general sort of mast cell activation. Beyond that, you know, there aren't specific uh, there aren't specific triggers that are universal. So many patients will report triggers, and I think I encourage them to keep a diary, oftentimes. But I also emphasize the fact that, oftentimes these are unprovoked, idiopathic type recurrent events. And so having sort of prophylactic treatment and then sort of a plan for acute treatment of the reactions, depending on what the nature of the reactions are, which could include, epinephrine, antihistamines, et cetera. And sort of emphasizing the fact that these are may not be extrinsic, because the fear is that sometimes patients start limiting foods or other things quite substantially, and then end up on, I had one patient who became vitamin B12 deficient because of such a limited diet. And so you have to really be careful in counseling them to not necessarily assume, every last thing that happened right before they had an event was a trigger necessarily. The other thing that's super useful is biofeedback, particularly in the mastocytosis patients, where you can help mitigate the severity of an episode, using sort of some mind-body biofeedback techniques. And there aren't great data, but anecdotally and clinically, it was something we did regularly for the patients at NIH and something that many patients I've had success with. And when I say there aren't great data, it hasn't really been studied prospectively, but the outcomes I think really speak for the use of that technique.
Thank you. Thank you for that. We have a physician that's stating that she has very many patients with hypermobility and many symptoms consistent with mast cell activation and respiratory GI tracts and skin, but no elevated tryptase levels. She's managing with antihistamines and sometimes gets as far as utilizing montelukast. But should she be monitoring tryptase levels each year to look for increase over time?
No, there's no reason to really trend the tryptase over time unless the symptom, like if you have, let's say you've had measured a couple and they're consistently one level, we don't generally recommend just trending tryptases in patients in that context, unless they have a known clonal problem and then they have new symptoms. Or some patients we trend probably once or twice a year if they have, or sorry, once a year, or once every other year if they have known clonal disease. But if they don't have clonal disease, there's no recommendation to trend their levels over time.
All right. We'll take one more question before we wrap up for today. Can you speak more specific to H1 and H2 treatments that you have seen work, ones to be wary of?
Oh, I see. Yeah. So H1, generally we recommend second generation and non-sedating. So those are, and the more efficacious versions. So that's going to be your generic, like cetirizine and fexofenadine are generally the H1s we recommend. For H2s, I don't know that there's any that's um, more efficacious or more specifically recommended than the other. And honestly, H2 blockade generally doesn't help. There's old literature that when patients were infused with histamine at the NIH Clinical Center like 40 years ago, you could see that like really they'd get widened pulse pressure, and giving both H1 and H2 would fix that, whereas H1 alone didn't fully fix it, and H2 alone obviously didn't. But anecdotally or clinically, most patients don't seem to improve substantially beyond H1 while on H2. But I should say, based on chronic spontaneous urticaria guidelines, up to 4 times the daily dose is kind of the standard approach for H1. In terms of things to be leery of, There are potential concerns for the sedating group of antihistamines for their long-term use. There's some sort of long-term outcome data in terms of risk for dementia and things like that. And in high dose and lower, especially in smaller kids, we had one patient who actually developed mild psychosis from off-target effects of sedating antihistamines. So I think it is good to be leery of lots of old school, although some patients will take like, diphenhydramine or Atarax or something like that at night to help sleep, which, I don't really sort of fret about, but we do discuss those potential risks.
You. Well, thank you so much, Dr. Lyons, again for this incredible presentation, for answering some questions here at the end. I know our attendees appreciate that. So in a few days, Zoom will email you with a link to the recording as well as a webinar evaluation and supplemental resources. Before we conclude today, I want to mention our upcoming webinar on October 8th. It's going to cover drug allergies, diagnosis, and treatment, presented by Dr. Castells, and she's going to explore the pathophysiology of drug-induced allergy reactions, diagnostic tools such as skin testing, drug provocation testing, and current therapies, including desensitization protocols and biologics. So please stay tuned and register for that. And as always, thank you again from everyone at Allergy and Asthma Network, where we strive to advance patient-centered research and advocate for better outcomes, access, and education for treatment. Thank you again, Dr. Lyons, for being with us today and for all of the attendees. Thank you so much and have a great day.
Thanks a lot.
Bye-bye.